Yeah, thank you so much for joining today, the Journal Club. Today, the paper we will discuss today address a question that becomes highly relevant during the COVID-19 pandemic. How can we determine the real world impact of public health interventions, such as face covering, when many factors are changing at the same time? Traditionally, epidemiologists have used statistical analysis, observational studies, randomized trials, and mathematical models to understand disease transmissions and evaluate interventions. However, complex public health events rarely depend on a single factor. Human behavior, social interaction, immunity, vaccination, seasonality, healthcare utilization, and viral evolution all interact continuously and influence one another. This is where dynamic causal modeling, or DCM, becomes particularly interesting. Originally developed in neuroscience to understand how different regions or parts of the brain influence each other, DCM has evolved into a broader framework for studying complex systems. Rather than simple identifying associations between variables, it attempts to model the underlying mechanisms that generate the patterns we observe in the real world. Terms CDM start with a hypothesis about how a system works. It then combines multiple sources of data and asks which explanation best accounts for what we actually observe. This allows researchers not only to estimate the effects of a specific intervention, but also to compare alternative explanations and explore what might have happened under different scenarios. The significance of today's paper extends beyond the question of face covering. It introduces a way of thinking about public health that integrates epidemiology, behavior, policy, and causal inference into a single analytical framework. More broadly, it raises important questions about how we evaluate evidence, how we estimate the impact of intervention, and how advanced modeling approaches might contribute to work in epidemiology, vaccine research, and public health decision making. With that context in mind, it's my pleasure to introduce our speaker, Bruno Alves. Bruno Alves is a public healthcare professional whose work sits at the intersection of vaccination, policy, epidemiology, health economics, and pharmaceutical science. He's currently pursuing a PhD in public health and health economics at the National School of Public Health of Nova University in Lisbon, where his research focuses on improving public health decision-making and reducing health inequalities. He holds an integrated master's degree in pharmaceutical science from the Faculty of Pharmacy of the University of Lisbon. He also completed a postgraduate training in healthcare project management with a focus on public health and international health projects. Professionally, Bruno has been working with the Portuguese Directorate General of Health for more than 4 years. He currently serves in the Vaccine, Immunization, and Biological Products Unit, where he contributes to the coordination of national vaccination and immunization strategies, including the National Vaccination Program, seasonal vaccination campaigns, scientific support to Portugal national immunization, technical advisory groups, and the development of evidence-based public health guidance. He was also actively involved in the national coordination of COVID-19 vaccination efforts during the final phase of the pandemic. Alongside his professional activities, Bruno has held several leadership and representative roles within academic and public health organizations, demonstrating a strong commitment to education, scientific engagement, and public service. So please join me welcoming Bruno Alves. Bruno, the floor is yours.
Thank you. I'm going to start the screen sharing just a little bit. Can you confirm that you are seeing my presentation?
Yes, yeah, we can see.
Thank you, and hello all. Thank you for coming, and it's really a pleasure and an honor to be with you. And I would like to thank the organizing committee for the invitation to be here today. So my presentation aims to promote discussion on this topic, can models, and specifically the DCM, close evidence gaps without opening new uncertainties. And I've already been introduced, but I will use this slide just to have two very quick disclaimers with you. The first one is I'm not a modeler expert, so if you have any very specific questions on how the modulation works and the mathematics behind it. I'm learning with you, so I'm very eager and available to study it with you and find out the answer. And the second point is I'm not expert in speaking English, so if, for instance, you don't understand the word that I'm saying, please interrupt me. It's very okay. Or if you want to comment on something that I'm saying, you are free to do it also. So regarding this session, what we are going to do is first trying to understand what is DCM, what is dynamic causal modeling, and Jose already said a lot on this, but I do believe it's very interesting to understand what is behind this methodology and what is new comparing to other more conventional modeling approaches. Then we will explore a very specific practical application of this modulation for evaluation on a public health intervention, which is the use of health masks. And we will then discuss this paper, its strong points. This is the paper that we are talking about, estimating the value of face COVID-19 epidemic. It's a very recent paper. It has been published in the final of last year. And the objective of the study is this, to quantify the impact of face coverings, both on the viral transmission in infections and on that associated with COVID-19 with data between 2020 and 2023 in the UK. And why does this matter? So actually, this was a very discussed topic on the pandemic, and it's very relevant to prior and epidemic or a pandemic that, as experts, we gather the most of possible data to anticipate this type of questions. It would be more easy if during the pandemic we already had answers regarding of the use of masks. But right now, the evidence of the effectiveness of face covering remains not very clear, contested. And the paper refers to this meta-analysis of RCTs, and I'm showing in the next slide some a figure referring to this. But right now, we don't have data supporting significant relative risk on the protection because of the use of masks. And the author of this paper argues that current studies still do not resolve these uncertainties. So they propose to apply this new modulation approach, this DCM, to answer this gap. I went to look this paper, so not the paper that we're discussing, the Greenhalgh paper with the meta-analysis. And this is a picture with a forest plot of RCTs on community. And in the gray arrow, I do believe it's gray, I tried to show to you the value that the authors cited regarding the 14% reduction on PCR confirmed influenza and SARS-CoV-2, but you can see it's not significant. And the only significant value that we have here and which would be relevant for our discussion, it's the green arrow one, which is the 11% reduction on influenza or COVID-19 like illness. And regarding the DCM approach, and most specifically the modulation that we are looking during this paper, this is the figure that we will be assessing. And maybe I will show this slide just for you to look closer. If you look into the green circle, it's a very conventional epidemiological SAER model. So you have the susceptible, the exposed, the infectious, and the recoverable model here. And it's very similar. But the new thing regarding the use of this approach is that we have three additional factors. Two factors regarding social behavioral data and one factor regarding clinical data. So the assumption here, and I will return here, that each person in the UK, in this case, is on a specific state on each factor. So it's on a specific state on the infection factor, a specific state on the clinical, and going on. But it cannot be on 2 or 3 states on each one of these specific factors. So they are mutually exclusive. And the parameters behind this model showed us the rates of transition between each one of these states. Additionally, when we look at these lines, these dot lines, we see that this factor interact with each other. So a person that is on a specific state, per interval on the susceptible state, don't have the same rates or the same odds that a person that is on the exposed state. So there are a lot of parameters, a lot of rates, a lot of data behind this DCM. The orange boxes that we are seeing here, the surveillance, the demographics, the testing, and the clinical, means the data that this model will generate, the outputs that that this model will provide. So these allow us to better understand what is underlying behind what we are trying to assess in a more complex approach than only a conventional SAER model would allow us to do. Regarding this DCM COVID-19 that we are looking into, and looking again on the green factor, this factor is duplicated. So you have both a vaccinated status and an unvaccinated status. And actually a person that is on a vaccinated status can return to the unvaccinated status. This allows us to better understand the waning immunity and consider it on the modulation. And all these factors will be duplicated to assess each one of these 4 age groups. I would also like to highlight some of the difference between the conventional agent-based modeling and what we are discussing with the DCM. The main difference is that agent-based modeling simulates a lot of individual agents and all their interactions. So we are talking about a lot of individual trajectories that model can simulate during repeated runs. While the DCM, it models probability distributions across population states. And considering these density dynamics and the prior parameters behind it, we actually only do one single simulation for each DCM considering its data. So it's a much more reproducible approach and much more efficient. You can run 5, 6, 7 times the same DCM with the same data, and will always return the same outputs. Regarding this specific DCM, it was used during the pandemic to provide long-term forecasts with data from 2021 to November 2023. So there are a lot of publications regarding the uses that this DCM had during the pandemic. So I assumed the validity of this model, and also the authors did it too. So for this discussion on this presentation, I will not discuss if the parameters are good, if the model is good. I will not discuss it. I will only focus on the adaptations, on the specific adaptations this group of authors did to assess the effect of mask use with this DCM. However, if you are curious on the use of this DCM, on the use of DCMs in general, or the specific technical parts behind it, there are a lot of citations in this specific paper that have very interesting reading for you to do. Regarding data sources, they use the very same original data that fed the DCM COVID-19 during the pandemic, with data which was available in November 2023. So we are talking about UK sourced data from the government, so it's official national data from the Office of National Statistics and the Health Security Agency, and with mobility data from Google. The new thing here is the use of additional time series on data, providing the self-reported use of face covering by adults. And I'm focused on this thing, adults, which are people with over 15 years of age, so 16 plus. Why this is relevant? Because they also talk about the effectiveness of the mask use on children, but they are not using data on the use of masks by children. They are talking about effects on children because of the use of masks by adults only. And this is the question that supported the gathering of data. In the past 7 days, have you used a face covering when outside your home to slow the spread of the coronavirus? We can discuss this question a little bit after this slide. However, I would like to highlight that these time series don't have any data regarding, for instance, what is the type of mask that people used, how consistent was their use. For instance, did they use all days? Did they use the mask every time they went outside? When they were with people that went outside during the day, did they use the mask? How did they use the mask? If they exchanged the mask very often or not? These questions were not assessed. This is the only question that supported the data they gathered, which was the self-reported use in the past 7 days. For the adaptation of the DCM COVID-19, I would like to show you actually this equation. I created this picture to better explain this. So they tried to model in specific the risk of transmission because they considered the probability of becoming infected depends on these 3 parameters: the prevalence, the contact rate, and transmission risk. And they consider that the face coverings will reduce the transmission risk. So for this, they write all these beautiful numbers, and I have a slide which explains a little bit on this. But I would like to highlight that ECM accommodates variations on this risk of transmission because of the emergency of new variants and because of seasonality effects. So this is the main equation that calculates the transmission risks at a given time. We have here the variance effect, and we have here the seasonality effect. What they did was supplement this seasonality effect with a face covering effect, which is this function M. After the definition of the model and the specification of the causal structure and the distribution for all the 61 parameters behind this model, they generate data, the green boxes that I showed you previously. And they compared the generated model data with the observed real-world data. And with this comparison, they did a new distribution of the parameters to converge the model with the real-world data. To do this, they used this variational Bayes Laplace methodology. After this, they used this Bayesian, I'm here on the box 5, model reduction, to compare the model with a second model in which there is no mask effect at all. So we are talking here about 2 models. One model assuming there is a mask effect, and the second model where they reduce the effect of mask to be near 0. And after that, they do the evaluation effect, the evidence, they make an effectiveness assessment, and they generate the counterfactual scenarios that I'm going to show in the results. This is just for you to see on the supplement tables. If you are curious, there are parameters, the initial or prior parameters that were generated here on the between step 1 and step 2, and the posterior parameters that are generated on step 4 after the comparison with observed data. You can see there the means for each parameter and the credible intervals and comments on these parameters. And now we have the results. And these figures, I don't know, okay, 15 minutes. Yeah. These figures we can see on the first one, on red, we have the real world data on new cases, new infections, and in blue we can see the model. So we can see that the data that the model show us, it's very near the real world data. And we can see the registered COVID-19 and certified COVID-19 daily deaths. So we have this comparison between the red and blue lines, which are the model generated, and the darker lines that we almost can see that show us the real world data. So the first interesting data is this one, the Bayesian model comparison. What it tried to show us is that for each one of these, and I'm going to focus on the age groups, not on the variants, we can see that the model that assumes there is an effect because of the use of masks, it's stronger than the model that assumes no effect at all of the use of masks, except for the younger adults. For the younger adults, the model that assumes the masks did nothing has stronger evidence or show us stronger evidence than the model that assumes there was an effect by the use of masks. So it means this effect was very trivial on this age group. For the other three age groups, it suggests there is an effect because of the use of masks. The authors also did this essay for the correlations between parameters to assess if these parameters were dependent on each other or if they were independent. These lines that you see, which show the highest correlation, actually are the parameters of the use of mask. So it's natural that the use of mask correlates with the use of mask. It's self-correlation. But for the other parameters in general, we see there is less than 0.5 correlation. So they assume low to mild correlation. And because of that, they assume that the face covering effect can be disentangled from other effects. This is the main result from this study, the effectiveness of face coverings. The points where the posterior probability density is higher is the most probable points on that age group. So, for instance, when we look at this young adult group, we have here the highest posterior probability density, which means that it's most probably that effectiveness on this age group is near 0. But for adults and elderly adults, it's near 5% effectiveness on these age groups. This graph also shows us the transmission risk evolution. When we see the yellow line, it assumes the effects because of variants and seasons. When we see the red line, it's effects of variants without the seasonality part. But when you look at the blue line, which is the most relevant for us, we also see the effect of face coverings on the reduction of transmission risk, which is lower. And this is the surprising part of this study, which shows the cumulative registered deaths on the model, which assumes there was an effect of mask, and the model which assumes there was no effect at all because of masks. And this blue line functions as a counterfactual, and you can see that the difference between one and another is very significant. It's more than 100,000 deaths saved in 30 actually months. So these are the big numbers from this study. On the left, you can see the effectiveness that they estimated. So for children, we are talking about 20% with this credible interval associated. For young adults, 0%. And for both adults and older adults, we have this 5% reduction in transmission risk. And we are talking more or less 100,000 deaths avoided with this credible interval of 14,000 and a lot more of deaths avoided. So what are the new stuff regarding this study? What does it add? First of all, it applies a new methodology, and it adds a specific parameter regarding the face coverings that the original DCM COVID-19 did not use at all. And because of this, integrates more than the 14 time series with this new time series regarding the self-reported use of mask. It also used this Bayesian model reduction to compare models with a non-trivial effect versus a significant non-significant effect for this effectiveness assessment. And it produces efficient and reproducible estimates, which are conditional on the data quality and model assumptions. The main conclusions that we already saw was the 5% effectiveness for adults. I'm not talking here about effectiveness of children because I do believe that the limitation on data on this age group is very significant, and it will illustrates or suggests how a very modest reduction in transmission may have a very huge impact on other health consequences such as deaths avoided. So it offers a sophisticated or more dynamic approach for investigating this evidence gap that as of now neither is or other more conventional models allowed to answer. For me, what are the limitations? The main limitation for me is the quality of the data they use regarding self-reported mask use, and I already thought on this because it provides no information on mask type, on how the masks were used, the context of use. The paper also mentions this part of externally validation. The data was not externally validated, so it was also a limitation to note. The authors assumed that there was no relation or dependency of the self-reported mask use parameter with other parameters, so they did not any further studies on this, but I would believe that it will be very interesting to do some studies regarding this. One strong limitation for me is the fact that for the model that the mask effect was removed, all the other parameters remain unchanged, which I don't believe it would be true because, for instance, in an alternative world where we did not use masks at all during the pandemic, maybe we have had different policies in place. For instance, maybe more confinement in place or possible different behaviors for us to use. Maybe we did not went outside at all if we had not used masks, so the parameters would have need to be changed because of this. And it would have been interesting to do some sensitivity analysis exploring not only these topics that I already discussed, but other prior assumptions regarding the parameters that already were in place regarding the original DCM COVID-19, for instance, regarding on the efficacy of COVID-19 vaccines, because we are talking about data that were available during 2021, 2022, maybe right now, we have different data regarding how does the COVID-19 vaccine work. And one thing that I would like to have a better understanding is this transformation of 5% transmission effect to 100,000 deaths avoided. So theoretically, it's plausible, but it would have been interesting to causally understand a little bit on this mechanism. But the main topic here is, as with any model-based analysis, the validity of what we are seeing depends on both the quality, completeness, and representativeness of the input data and on model assumptions. And these are the key messages that I would like to share with you. But my main thing here to talk about is the importance of having good data, good access to data, to have this type of more sophisticated modulation approaches, because if this DCM COVID-19 had better self-reported use or use of masks data, the findings more credible or more strong, and it's very relevant to, after the pandemic, continue the culture of trying to improve the data that we use for this type of studies. However, I do believe that this approach, this DCM approach, can provide a very good and interesting alternative to conventional modeling approaches, particularly when we have massive amounts of data to use and to study. And this is the quote that I would like to show to you to complete this presentation. When fit for proposed data, transparent assumptions, and multidisciplinary scrutiny. And I'm focused on the multidisciplinary scrutiny because we are here in a group of people with different profiles, and this is a very specific thing of public health. We have very multidisciplinary teams. So different people can look at the same data, the same results, and have different perspectives. So it's very interesting, and each highlight the credibility and the importance that discussing this type of studies can have for decision making on public health. These are the references. I can show, send to you the presentation after this, and thank you.